All right, outstanding. Well, thank you for that introduction, Kate. I appreciate it. My name is Phillip Yuhas. I am an assistant professor in the College of Optometry. In the College of Optometry, I have a couple different hats. I see patients in the clinic. That's where I'm coming to you right now. We just got done with a full day in the clinic with the students seeing patients. I also do research here at the college. I'm able to do traumatic brain injury research. I'm privileged to do that. And I'll talk with you a little bit about what that research is today. And then I also get to do other odd jobs around the college here that they have me do. So I love my job. I love working with students, and I love working with patients and subjects who have had traumatic brain injury. And I hope to give you a little bit of background tonight on how vision works. How does the eye see? That's a question I think a lot of people have that people don't know. We'll talk about how do we assess the eye, especially in the context of traumatic brain injury. And then finally, what traumatic brain injury and TBI and vision related research is being done here at Ohio State. And I will talk mostly about my research because that's what I know best, but there's a lot of other good stuff going on as well. So let's talk first about how vision works. So the first thing you need to do to see is to have light enter into the eye. So as you look on the left here, I have a picture of an eyeball staring back at you. And most people know the different, at least some of the different components of the eye. The iris, of course, is the colored muscle right here in the center of the eyeball. And then in the middle of the iris is the black pupil. And what most people don't realize is that the pupil is actually a hole in your eye. The cornea covers it, so the eye inside of the eye is not open to the world, but the pupil is actually a hole. And what that hole does is it lets light from the world, from the environment, into the eye. So that's what I'm showing you here on the right. Light enters the eye through the pupil and then is focused by the cornea and a lens inside the eye on a structure called the retina. So the retina is actually a part of your brain that extends into the back of the eye. And the analogy that I use with patients often is that if you think of your eye as a camera, the retina would be like the film in the back of the camera. So the first thing that needs to happen in the vision is that light from the environment needs to enter the eye through the pupil and then be focused onto the retina. And then the second step can happen. So the second step happens when light that's focused onto the retina is converted into an electrical chemical signal, and that is then signaled to the brain and sent to the brain. So here is on the left a slide. So this is a dissected retina showing you the 10 different layers of the retina. So light actually will be traveling from the top of the screen to the bottom, and you can see there's all these different layers in the retina. I won't bore you with the different ones, but know that this guy down here, PL, is actually the photoreceptor layer. And even if you have only a little bit of knowledge of the eye, most people have heard of rods and cones. And the PL, the photoreceptor layer here in the retina, is the part of the retina that contains those rods and cones. And it's primarily the rods and cones that actually capture that light that's focused onto the retina and begin the process of changing that light, shown by the green arrow here, into a signal that is then sent up through the different layers of the retina and back to the brain. And I'll talk more about that in a second. So how do we assess the retina? Well, one of the ways that we assess the retina is through a technology called optical coherence tomography, or OCT. And that's the image that I'm showing you in the middle of the screen here. OCT, you could think about it as an ultrasound, but instead of using sound waves, it uses light waves. So here is a cross-sectional view of the macula, which is the central part of the retina, in the back of the eye. So what we're looking at here is actually a cross-sectional ultrasound of your retina, which is to say really that this is a cross-sectional ultrasound of your brain, because remember, your retina is a forward extension of your brain. We can't get images this pretty and this pristine of the brain anywhere else, even with some of our more advanced MRI technologies. So this is pretty much as good as it gets right now in terms of imaging the brain. We do that in the back of the eye because it is so accessible to us. Oops, I jumped ahead too much. The third step in the vision process is the signal that's generated by the rods and cones in the back of the retina after light is focused onto the retina is to send that signal back to the brain. So as you can imagine, the eyes and the brain are separated. So we have to get that signal from point A in the eyes to point B in the brain. And that process begins in the retina itself, where the photoreceptors or rods and cones at the bottom of the image here sends that electrical signal up through a 3-cell relay path in the retina to a group of cells called ganglion cells. So ganglion cells are retinal cells, and they have long fibers that actually project back from the retina to the brain directly. And that's what I'm showing you in the middle figure here. So this is a drawing of the retina looking straight on. And each of these lines here that course back to this circle represents a fiber from one of these retinal ganglion cells. And all those fibers gather at this part of the eye out here and create a big bundle. And that bundle is called the optic nerve. So all the fibers from the retinal ganglion cells all travel back in the eye to this one area where they meet up, form a large bundle that then goes back into the brain. That bundle, again, is called the optic nerve. You could think of the optic nerve as being the cable that connects the eye to the part of the brain that processes the image that the eye captures. And that pathway is shown here on the right. So we have the eyeballs up front here, and then they send the optic nerve and the fiber of those retinal ganglion cells back to different targets within the brain. So the eye itself sends its fibers back into the brain. And as it sends those fibers back into the brain, those fibers are actually vulnerable to the same traumatic forces that damage the brain in a traumatic brain injury. That's why one of the reasons, and we'll talk more about this in a second, but that's one of the reasons why the eye is such an appealing site to detect changes, neurological changes associated with traumatic brain injury, because it sends its fibers back into the brain. Those fibers can be affected by the mechanical forces of traumatic brain injury. And we can see the retina. We can see the eye very easily with our clinical tools. It's not so easy to see the brain in the same way. So this slide shows you how the eye can be affected with traumatic brain injury. And I introduced this in the last slide, but we'll just build off a little bit more. So the mechanism that causes most traumatic brain injuries is a coup, counter-coup injury. And so what that means is when you have a traumatic brain injury, as shown here on the right side of the slide, the brain sloshes forward, bangs into the front part of the skull here, and then you have a recoil backwards. And then the brain sloshes into the back part of the skull. So it's like a 1-2 punch with the initial forward motion or jerk of the head causing brain injury on one side of the brain. Then as everything bounces back, there's an injury on the opposite side of the brain. And as this twisting and shearing of long fibers within the brain itself occurs, those fibers from the eye get caught up in that and can be potentially damaged by this mechanism that I just talked about. There's another thing that goes on in the brain called transsynaptic degeneration, where an injury in one part of the brain spreads to other parts. So we know that if you have an injury in point A of your brain, that injury, the inflammation and degeneration associated with that injury can actually travel across space to other parts of the brain. And that travel across space could actually include into the eye itself. So these are the two reasons why the eye itself might be a target or might be affected by traumatic brain injury. And like I've said before, the eye is a wonderful area to actually detect these changes because it's nature's brain slice. It's like a histological slice for us to look at. The reason being is that the retina arises from brain tissue and shares the brain's vascularization pattern. So I'm showing you on the right here, this is actually the developing brain in a human embryo. And you can see this pocket that outcrops here is actually what will later on form the eye. So the eye, it branches off and bubbles off the brain very early in development. So it shares many of the same neurological symptoms, characteristics of the brain. And what's more so, like I've said before, we can actually look directly at the retina. So we look at the back of the eye. Of course, we look at the eye's health as well, but you also get a sense of the brain's health. And that's what I'm showing you down here on the right. This is a standard clinical view that we see when we look at the retina. Again, we're looking at the eye, but we're also looking at the brain itself, okay? And so when we do our clinical assessments, we think, okay, how can we detect traumatic brain injury in the eye? Well, traditional ways of assessing vision in the eye, including the eye chart here on the left, visual field, side vision, peripheral vision testing here in the center, and then our standard clinical techniques that I'm showing you here on the right, sometimes cannot detect changes to the eye that are caused by traumatic brain injury. They're not sensitive enough. So we need to use other factors associated with the eye to detect changes. Those factors potentially include measuring eye movements, and some of my colleagues here on this panel will talk more about that. We can measure the thickness of the fibers in the back of the eye and the retina to detect those changes potentially with TBI, and we can look at the pupillary light response here on the right to detect those changes. Because as we'll talk about in a second, the pupillary light response is highly correlated or is highly influenced by your brain. So in my lab, what I'm doing is I am actually measuring the thickness of the retina, both in the center part of the retina called the macula, and then around the optic nerve itself in a part of the retina called the retinal nerve fiber layer. I'm measuring the thickness of the retina in patients who have had traumatic brain injury before. And so that's where the crux of my traumatic brain injury research is going on. We're almost done with this study. But what the preliminary results of this study show is that we're actually finding thinning in the back of the eye in patients who have had multiple traumatic brain injuries. So again, this suggests that the neurological changes and the inflammation and the degeneration that's occurring in the brain is actually starting to show up in the back of the eye in a very objective and quantifiable method. And the exciting thing about these results from my lab are that they come from a diverse patient population. So other people have shown these types of changes, but it's in soldiers, it's in football players and boxers, usually male, and they've usually come from the athletic realm or from the military. My patient population is equally split between males and females, and very few of them are athletes, if any. So these are people who have had multiple concussions out there in the real world from falls or car accidents or what have you that are showing these same type of results. So I think that the results that I'm presenting here suggest that it's pretty generalizable, the idea that you can actually measure objective changes to the structure of the back of the eye in patients who have had traumatic brain injuries, and maybe these structural changes in the back of the eye correspond to neurological changes that are occurring in the brain. Like I mentioned before, and I'll end on this, you can also measure your pupillary light reflex. So how does your pupil respond to light and to detect traumatic brain injuries potentially. So the pathway that controls your pupillary light reflex is very complex, going from the eye to multiple centers in the brain. So like we talked about before, if you have this shearing and counter-coup injury in the brain in response to traumatic brain injury, these axons and these projections and these fibers from the eye can get caught up in that mechanical stress and become damaged. And what my lab is doing is we're looking at a specific type of cell in the back of the eye and the retina. And this is an image from my lab where I've stained the cells that we're looking at to see if these cells that send their long fibers back into the brain are affected by traumatic brain injury. And what we found by looking at the pupillary light reflex, because these cells that I just showed you help control the pupillary light reflex, is that patients who have had traumatic brain injury have a very variable and very sporadic pupillary light response. So what I'm showing you here is over time on the x-axis and pupillary constriction on the y. With each pulse of a blue light, the pupil constricts, then the light turns off, it redilates, when it turns back on, it constricts, and so on and so forth. And you can see this figure on the left here, these blue lines are way spread out, and so are these black dashed lines. That means our patients with traumatic brain injury have variable pupillary responses compared to healthy control patients here on the right, where there's not a lot of variability in the pupillary light reflex. These blue lines are much tighter and the black dashed lines aren't very far apart. So my take-home points for you today are: light enters the eye through the pupil and is captured by the retina. The retina is a direct forward extension of the brain and is highly accessible in the clinic. TBIs may damage the retina and alter the pupillary light response. And so going forward, and this is the research that I'm interested in, is that the eye is a potential platform for the objective detection of traumatic brain injury that is not That is not done right now. We detect traumatic brain injury and diagnose it very subjectively, but the eye has potential to be an objective site for the detection and management of traumatic brain injury. Thank you for your attention.
Okay, so I'm Dr. Sara Huffman. I am a faculty member with the Department of Ophthalmology, and I see patients at OSU's Dodd Hospital. We have a neurovision clinic here, so it's a really great collaboration between optometry and occupational therapy. So I work with occupational therapists, and we evaluate patients and do full comprehensive eye exams when they're kind of in the acute stage of their brain injury. So Dr. Yuhas did a great job of explaining how the brain and the eye are connected. And I kind of want to talk a little bit about what we see acutely in brain injury and what symptoms and things like that people might be noticing after brain injury. So studies vary a lot on how many patients are experiencing vision issues after brain injury. The most recent study I found showed about 50 to 75% of patients can experience brain injury. And like Dr. Yuhas pointed out, the fibers go all the way back through the brain. And so any place in the brain that you have damage, there's a potential that you could have some visual complications because of that. So again, he mentioned the nerve fibers carry signals from the eye all the way back to the brain. And the image I have here on the side shows that the same kind of similar to what he showed. The fibers start here at the eye, they can go all the way back to the brain. But in addition to the optic nerve, there are also nerves that control the eye muscles. And so those muscles are getting signals from the brain, and those signals can be damaged as well with a brain injury. So not only can we have damage to the optic nerve, but you can also have damage to the nerves that control the muscles that surround the brain. And that can cause your eyes to drift out or in, up or down, or even tilted. And that can cause a lot of issues as well. Where the damage is in the brain can also show what symptoms you might be having. So as a doctor, if we know where the damage has been, that can help us to know what kind of symptoms that the patient might be having and to isolate things a little bit better. The very back of the eye is called the occipital lobe, and damage to that lobe can have a lot of visual complications as well, not only to your eyes and your vision, but also to your visual perceptual skills. And I think those are going to be touched on a little bit later as well. And we also can't underscore the fact that ocular health can be involved with this as well. So not only can you have issues that come from the damage that you've had to your brain, but when you have an injury to your brain, you can also have damage to the eyeball itself. And so a lot of times in clinic, what I'm looking at is the damage to the eyeball itself, and is that something we can fix and make better? Or is the damage coming from the brain and just affecting the vision and the visual field? So that's something that eye doctors can tease out and piece through, but it's an important differentiation to make. So common vision complaints when people have had injuries to their brain, blurry vision is something that we hear a lot of. Double vision, and double vision from the picture I have here can be side by side double vision. It can be up and down. It can be diagonal. It can be two very distinctive images, or they can be so close it almost seems like blur. Peripheral vision loss is having trouble seeing off to the right or the left. That can range anywhere from a complete blacking out of your vision on one side to just forgetting to look to one side. So you can be ignoring one side and maybe it's running into objects, or can't find the remote control and there it is on the right or the left. And so that's something that can, like I said, have a wide range of different variations. People can feel like they have an increased sensitivity to light. They feel eye fatigue or eye strain. And that can go into difficulty with hobbies. They can have trouble with reading, trouble watching sports, sewing and doing fine detailed work like that. When people have headaches and dizziness, that's not uncommon after a brain injury, but there can be visual reasons for that as well. So that's something to rule out if someone has longstanding headaches or dizziness. And it can even be if your vision is clear, but you're very overwhelmed by busy environments. We see that frequently, where if you're going in to watch a game, or if you're going into a shopping mall or a restaurant, there's a lot going on. And that can be very overwhelming from a visual standpoint, even if you can see things clearly and still have 20/20 vision. And sometimes it's not even the patient at all that notices these symptoms, but family, friends, therapists may notice signs of visual issues. and let the patients know about it. So maybe the patient doesn't realize they're running into things on the left or missing things on the left, but the family will notice it. Or maybe the patient doesn't think they have the double vision, but they're frequently closing one eye. Or as you're watching, someone's looking at the patient or looking at a family member, they're not blinking their eyes equally on both sides, or one eye is more red than the other. Sometimes family will notice that an eye is actually deviated out or in, and the patient doesn't complain of anything, but something that family or friends might notice, or that an eye is shaking or twitching even. And so if you have visual symptoms, what's the next step? And really, your primary eye care provider is going to be the best place to start, because they are going to be able to figure out what the cause of the issue is. And then if they can't help you themselves, they can get you to the next best place to go. So you really need to be upfront with the details of your injury and what symptoms you're having. That's going to help them pinpoint exactly what needs to be done next. But be aware that sometimes a primary eye doctor can't do all of the things that might need to be done to help. We often refer to patient or to specialists that do low vision or binocular vision or vision therapy. We refer a lot to neuro-ophthalmologists. And then sometimes if there's ocular disease things going on, we send to an ocular disease specialist or a retinal specialist. So just knowing that it might not be a one-stop shop. We may not be able to fix all of the issues in one visit. It may be going to a specialist after that. And a lot of questions we get are, how long is this going to take to get better? And sometimes there are things that we can do to help symptoms. And sometimes we can make things a lot better for patients in the short term. And then sometimes it's something that we just have to wait and let the healing process occur. So in general, we don't like to say anything's permanent until about 6 to 12 months after the brain heals and after the brain injury. We give it time to heal. But that doesn't mean you want to wait 6 to 12 months before you get seen. Because like I said, there are things that we can do and accommodations that we can make at times to make things a lot better for the patient while they're healing and to help things along the way. And I also wanted to stress that good communication is really important among healthcare providers. So if you're seeing an eye doctor and they're treating you for something, really important to let your therapist know about that, or ask them to send a letter to your therapist or to your primary doctor that you're working with, because if they are working on things with vision, that's important for your other therapists to know. Maybe they need to know what size font is best for you, or maybe they need to know what kind of treatments you're doing with your eye doctor to help with your other therapies. So good communication is a really important tool, and letting all the people you're working with in on that is really helpful as well. I think that's all I have.
So I'm Jodi Jones, and I'm an occupational therapist at Dodd Rehabilitation Hospital. And I work with Sara Huffman. She comes in once a week, and we see all kinds of patients, but mostly brain injury patients in our clinic. And I'm going to talk tonight about the impact of vision impairments after brain injury, as well as who can help with vision issues. We kind of talked about that a little bit already, but I think it's helpful to know exactly what your treatment team would be doing with you in an evaluation and how they can help. So this is a list of common deficits that we see in our clinic. This is not an exhaustive list. There are a lot of actually perceptual dysfunctions that we see in the clinic, but I will go over those towards the end of the presentation, the ones that we see the most in our clinic. So I won't spend a lot of time on this slide because I'm going to dive right into visual field loss. And pardon my rudimentary PowerPoint skills here, but I couldn't find anything online that really illustrated the visual fields that I liked, so I made my own. For central field loss, these folks, obviously that red spot there right in the middle of their visual field, it's going to affect a lot of things: reading, writing, self-care, eating, driving, of course, walking around, ambulation. So central field loss can be pretty devastating for people. An inferior field loss is illustrated here. These folks are going to have trouble just walking along the sidewalk. They may not see that huge crack that's in the sidewalk, or they may not see the dog. You get up from the couch and your dog's laying there on the floor. So they can't see them because the visual field has been occluded. And then the superior field, this is a problem at the top of the eye. This is going to probably affect you more if you're walking along a street and you need to look up to look at a crosswalk sign or to read the signs of the cross street. So anything that you want to look at the fall leaves falling, it's hard to look, or you can't see when you're looking up. You have to adjust your vision. And then hemianopsia. This is when you have a visual field loss of one side of the eye. And typically people will say, well, I can't see out of the right side of my right eye. But most of the time when we see them in clinic, they may be the right side of both eyes or the left side of both eyes. So that's called a homonymous hemianopsia. So we work on visual fields with people to develop a strategy for scanning. So before you get up from the couch or before you head down the sidewalk, you start with a strategy depending on where your visual field loss is, so that you can prepare yourself and make sure that you're seeing everything in front of you before you move about. So people with ocular muscle dysfunction, this is the muscles of the eye are not helping the eyes line up straight. So diplopia is something they may experience. The term for that would be double vision that you've probably heard most of the time. Some of these folks, they'll say they have some vertigo issues, or they may feel confused or clumsy because they're not quite sure which image to look at. So one eye is looking out this way and the other eye is looking forward, and that sometimes can alternate. So it can really make people feel confused or clumsy because they may reach out for their coffee cup and they're reaching for the wrong image. So that can be embarrassing for people too. Motion sickness is often something that we hear from people. They feel just kind of queasy all the time. And they also don't know where their body is in space. They just have poor spatial awareness, again, because they're seeing two images. So eye movement disorders, there are two skills that we all employ. The first one is a saccades skill, and that's the fast simultaneous movement in the same direction to change the point of fixation. So in the example you see here, the person starts out pretty good. They're going from word to word, and then they overshoot a couple of words. And then at the end of the line, they miss a word, and then they go to the next line, they miss the first word. And then it just kind of devolves into chaos there in the second sentence. So sometimes these people have to reread sentences, or they have to even use an anchor, which can be something as simple as a ruler, a 12-inch ruler, and you line it up on a page and you take your finger across and just make sure that you get every word when you're reading. And pursuits, these are eye movements that are smooth, continuous viewing of a moving object. So this person in this example, they're watching the airplane go through the sky. I like to watch airplanes go through the sky, but more commonly, you may have a child playing soccer on the soccer field. Kids on a soccer field do not make any sense. They are very erratic and very difficult to watch as they're running around and playing. So having smooth pursuits is going to be important because you need to be able to track that moving object. And just to kind of give you a little idea, what you would do to treat that is I think they're fun activities. You may not think they're fun, but working on mazes or word searches, crosswords, Sudoku, if you're a numbers person, all of those things would work on saccades because it's working on your eye movement. And then there are some apps out there that people can put on their tablet or on their cell phone that can work on both saccades and pursuits. So for accommodative dysfunction, This is a very common deficit that we see in our clinic following a brain injury. And these people will have problems with near work. So reading, handwriting, if they do jewelry work or cross stitch or anything like that, they're going to have a hard time and they're going to feel like they're really concentrating really, really hard, or they look like their concentration has been affected, or they're not comprehending, but it's because they can't see what they're looking at. And they're trying really hard. They look like they're focusing really hard on those images. And it can cause eye strain and visual fatigue. And I would even go as far as saying it causes a general fatigue for people. You're just exhausted when you try to do a vision task, when you're trying to work through an accommodative dysfunction. And I would also like to point out that to be sure that you're working on the right thing, that you would go see someone like Dr. Huffman, Dr. Yuhas, to make sure, or your eye care professional, to see what your accommodative skills are. Binocular dysfunctions, these are called vergence eye movements. So if you can do this right now if you want, but to cross your eyes and look at your nose, that is convergence. And then to take your eyes back out into the distance, that is divergence. Some people can have one or both of these insufficiencies, but you definitely want to have an eye care professional diagnose this before you start doing too many strenuous exercises for this insufficiency. Now, visual neglect is one of my very favorite things to work on with people. It's very frustrating for the clients as well as their family members, because the family feels like they're being ignored. The patients come into our clinic sometimes and they have 100% 20/20 perfect vision, but they have this dreaded neglect. Their brain just is not able to recognize what's going on in their environment on one side of their space. So I enjoy working with these clients, like I said, but they get pretty frustrated with it, as do the family members. So I tell people that have neglect, if you can get a watch that goes off every 15 minutes, that will make it be annoying. It'll be super annoying. So you have to turn it on. You have to turn your head into that space and turn your eyes over there to manage the watch. Sometimes if somebody's a jewelry kind of person, putting a jangly bracelet on that wrist to create more attention to that side. I tell people in clinic all the time, wherever the commotion is, put it on that affected side so that it will force the loved one to look and pay attention to that side. Sometimes it's difficult to differentiate between the visual field cut that we mentioned before and spatial neglect. However, I don't know what the studies are. I haven't looked into this, but I feel in my own experience, patients who have a visual field cut know something is up, but people with neglect have no idea that it's happening. So first and foremost, we need to educate people if they have either one, of course, but the treatment is pretty much the same. It's about paying attention and scanning to that area. And unfortunately for people, neglect does come with it an increase of falling. So vestibular dysfunctions, people will have blurred vision, they'll have nystagmus, which is a beating of the eyeball, sometimes both together. Oscillopsia is just a feeling that very unsteadiness in the world, and their posture, they think they would swear to the ends of the earth that their posture is perfect, but they're hanging off the side of their chair, again, because they're not oriented to their space. They don't know what's going on in their world. They just feel a sense of uneasiness because of that vestibular feeling. And of course, I list here the difficulties. It just affects everything. Imagine trying to lay down to go to sleep and your world is spinning and all you want to do is sleep because you've had a rough day. Of course, driving is affected, work and school, and also leisure, because you may start limiting going to the office, or you may dread going to class or going out to see your friends because you have this feeling that you're going to fall down all the time. So a couple of the perceptual dysfunctions that we see, form discrimination. Imagine you're very thirsty and these two things are sitting at your bedside table. Some people may not realize that, yeah, the urinal is there and the water jug. They just see a white object with a handle. So we want to make sure that this is not an issue for people. That would be bad. Or sometimes a button can be the same size as a quarter. So you go to the vending machine and try to pay with a button. That's not going to get you very far. Depth perception. So this is again not quite knowing how to judge the distance from your body to an object. So one way to work on this is to put a non-skid and a brightly taped surface on your steps. Also, you see here that there's a handrail so that you can tactily feel your foot on that non-skid and you can feel safe while also holding on to the handrail. Figure ground. So the picture on the left, if you see 4 ladies with their heads pointing in towards each other and the 5 vases, decorative vases, then you're doing really great. But of course, hopefully we all have this drawer on our homes. I have one in my kitchen right now, but this person's going to have a hard time finding the one object that they need out of this crazy drawer. So imagine if you have trouble with figure ground and your spouse says, "Hey, honey, go get the light bulb." You may have to take every single object out of the drawer just to locate that light bulb because you can't find it in all that chaos. And visual imagery. So this is the inability to use your mind's eye or your imagination to create a scene or to even create the human body in your mind. So I've had patients, can you draw the layout of your house? So it's really hard for them to even draw like a rudimentary floor plan of their home, something that they've lived in for 20 years and they can't do it. I've had patients who have tried to draw a stick figure. Just draw me a stick figure of a man, and they can't do it. So this is usually a body image issue. So we want to work on that as well. And I'd like just to say that any or all of those deficits that I mentioned, they can have an impact on everything. So your self-care, ambulation, all of your work, school, leisure activities, your community, getting around the community, and of course, driving. Everyone wants to know when they come to clinic, "Oh, you said I have 20/20 vision. Does that mean I can drive?" Not necessarily, because there are a lot of other things that go into driving besides vision. Obviously, perceptual skills need to be intact. Your hand-eye coordination needs to be great. And you also need to be able to physically tolerate driving. Sitting upright and being able to operate all of the controls is important as well. So how can vision experts help? So through quantitative assessment, this is data. We're gathering data to see your accuracy with tests, the timing or how long it takes you to do a test, the amount of assistance that you needed to complete the task, or if you needed any cueing to get through it. And then qualitative assessment just through clinical observation. I'm an occupational therapist and I learn and I can see a lot, believe it or not, about vision and perceptual skills just by watching someone get dressed or to take a shower. So that's what we're doing in our OT assessments, is we're observing. And in a dynamic assessment, this is when the evaluator and the client are working together to come to a conclusion, to do the assessment. So the client is doing an activity and the evaluator is giving them feedback and giving the client some suggestions at the time to see if that will work out. And I also want to know, what are your roles and responsibilities? What makes you you? What are your goals? What do you need to be able to get back to in your life? And I also want to know from my friends, Dr. Huffman and Dr. Yuhas, is this something that's fixable with a pair of glasses? Is it something that we can put a prism in your glasses lens? Or do you just need artificial tears because your eyes are dry? I want to know if things are fixable, or if it's a visual field cut that's not resolving, then we probably need to work on something more adaptive for you, something that's going to maybe not ever be back to normal, but will make you functional and get you back to your life. And I thank you.